Okay, I think we're going to get started. So welcome to today's webinar, Unpacking Ontario's Approach to Connected and Convenient Care. We'll be doing a deep dive into the new Your Health Plan, recently released by Ontario. But first, I'd like to acknowledge that today is International Women's Day and express my appreciation for all the amazing women at Santis and those joining us on today's call. I'm Stephanie Gower. For those that don't know me, I'm a principal at Santis and I lead the Ontario Government Relations team. For those that aren't familiar with Santis, we are a health and life sciences sector consultancy. Then we focus on strategy, policy development, comms, and stakeholder engagement, as well as government relations and advocacy. We have offices in Toronto, Ottawa, and Vancouver, and we're really looking forward to this chat today. For today's webinar, I'm joined by some of my Santis colleagues, and I'm very much looking forward to this conversation, as I'm sure many of you on the line are as well. I'm joined by Dan Carbon, Managing Partner and Founder of Santis Health, Ben King, Santis's Director of Digital Health and Innovation, and Ian Chesney, who is an Associate of Santis and is our regulated health profession expert. So just a bit of housekeeping before we get started. Please use the Q&A function at the bottom anytime throughout the presentation for any questions, and we'll leave ample time for questions at the end. As with all of our webinars, the slides and a recording will be emailed out after and posted on our YouTube channel. And lastly, if you don't mind, please take a few minutes to complete the survey you will receive via email at the end of the webinar. Your responses are very helpful in informing our future webinars. So today on the agenda, next slide, please, Taryn. We're going to be setting up the sort of context for our discussion with a bit of a refresher on the political and policy landscape in Ontario and looking at some polling. My colleagues will then unpack the Your Health strategy and corresponding legislation. We'll discuss what's next with the Your Health strategy, Ontario's upcoming budget and the spring legislative session. And finally, we'll get to your questions. There's a lot to cover today, so we hope to leave enough time at the end for Q&A. So we're going to jump right into it now. So the best place I always find to start is with a little bit of polling. And next slide, please. This polling shows the green top row is recent polling from Main Street Research from early February. And the light blue line represents the June 2022 general election results. So as you can see, there have been really no significant changes or deviation from the election time. Everything is still within the margin of error. Really still showing strong support for the PC government across Ontario. Even with the substantially divided opposition with a leaderless Liberal Party and the NDP anointing their new leader without a leadership contest. So not much has really changed since the general election last year. Next slide, please. With the recent introduction of the Your Health strategy and the legislation, I think several market research firms have been looking at the sort of state of healthcare across Canada, especially around the private delivery aspect of healthcare across the country. This poll really dives into, and this is from Ipsos, published February 6th, dives into the Ontario numbers, with the majority of Ontarians really strongly or somewhat agreeing that they would be support the private delivery of publicly funded services. It's about 55% of Ontarians. And majority of people were not supportive, not surprisingly, of private healthcare for those who couldn't afford it. I think what's interesting about the polling in today's context is that 52% of Ontarians think the health system really needs more money, which should come through the introduction of new user fees, which is what this poll found. And we'll get into that in the context. I'm sure many of you have been seeing the Financial Accountability Office report coming out this morning on health sector spending review and with the upcoming budget. So we'll get into a bit of that discussion later on as well. Next slide, please. So the FAO report this morning, just in case you haven't seen it, shared that from the 2022-23 timeline to 2027-28, the province has allocated $21.3 billion less than what will be needed to fund current health sector programs. and deliver on program expansion commitments in hospitals, home care, and long-term care. And I just felt that it would be remiss for not mentioning that in sort of the spending budget picture discussion before we get into the Your Health plan as well. With this report in mind, the report suggests that by 27-28, Ontario will have actually less hospital capacity, similar home care capacity, and less long-term care capacity compared to what it had pre-pandemic in 2019-2020. And that's despite the $40 billion commitment from the government. So it's clear that there are significant gaps that need to be closed moving forward. And I know that there's a lot sort of transpiring on Twitter and in the press conference that the Premier and Minister Bethlen Falvey just had on this as well. And I'm sure my colleagues will share some insights on this. Also, the government has had to juggle its sort of fair share of negative FAO reports recently, I would say, but it doesn't seem to have impacted their the public perception of this government. So what are we looking at moving forward? The Minister of Finance is set to release the budget, and I'll get into this later on March 23rd. And he really has shared limited information thus far, but about sort of their government vision for growth and to be an economic engine of Canada and frankly, North America. And looking ahead at different types of infrastructure, not just for the existing population, but the population in 15 to 20 years. The minister is looking at a bold vision, to grow and ease pressures on gridlock, number of schools, healthcare, but he's been really silent on many of the details yet. So we'll be looking forward to that in the budget upcoming. Next slide, please. This is one of my favorite slides, as it really just shows sort of how a lot of the health policy priorities have remained consistent over the last 3 years. And obviously during the pandemic, but have also shifted, and a few have been put on the back burner. COVID-19 obviously no longer a main point of focus for the health system, but there are a lot of sort of system-wide issues that have still yet to be dealt with, partially due to the sort of transition from pandemic response to dealing with implications from the pandemic. I know that those in the system, and probably a fair share of you on the line today, have seen significant delays in a few of the major programmatic areas: home care modernization, public health modernization that really stalled as a result of the pandemic. OHT development has been, I think, significantly slower than many of us have anticipated. And I know Dan will touch on a number of these topics as well. Next slide, please. So lastly, what does this all mean in the bigger context of our discussion today with the Your Health plan? Ontario is really in a strong position politically. The PCs are doing very well. And the latest announcement of the Your Health plan has not really impacted their public perception polling. They're really strong fiscally as well. The fight against COVID-19 is no longer the number one focus. And really the massive change that's occurring in reshaping the health system as a result of the pandemic is now the number one priority for the government in the health space. I think they're really well positioned to decide what those further priorities are, and we're really anticipating a lot of that will be outlined in budget 23-24 on March 23rd. So with that, I'm going to pass it over to my colleague Ben King to walk you through the Your Health strategy and really do a deeper dive into the legislation.
Thank you very much, Stephanie. So the remainder of this webinar really is going to be going through the Your Health strategy to explain sort of what it says, but also what the sort of import of what it says is and what it sort of means. And then we'll have some time at the end for a bit of a Q&A to elaborate a little bit on this. So just as a kind of basic context setting piece, if you're someone who has not been paying any attention whatsoever to the Your Health strategy over the past month and don't know what it is in a very basic way, what it is per this first bullet point, it's a rearticulation of past announcements. So over the last year, government in Ontario has made a large number of announcements about different reforms to the healthcare system of different scales. And with the exception of one or two relatively minor pieces, the sort of new quote unquote Your Health strategy really is just a packaging of all the things government has announced or envisioned over the last little while, and trying to turn that package of past announcements into a coherent vision, which basically says, we've announced a whole number of things in a bit of a piecemeal fashion, but actually there's a method to this. All these different pieces complement and reinforce one another, and they all sort of jointly move together to try to create the healthcare system that we think is needed to meet the needs of Ontarians into the future. So it is a strategy, but it is not a new strategy. It's not really breaking new ground exactly. It is by and large taking everything the government has been doing and packaging it and illustrating how those things cohere into something. There are a lot of different pieces to the strategy, which we'll kind of get through. But I think the sort of number one with a bullet priority of the strategy, the thing that most of the announcements feed into is the idea of trying to improve system capacity post-pandemic. We all know that in the pandemic, the system was strained in a large number of ways, but there's also a sort of acknowledgement that our capacity was not sufficient before the pandemic. Wait times were too long, it was too hard to find a family doctor, etc. And so the idea is to refocus Ontario's efforts on how you improve capacity moving forward, so that as the population as you try to catch up on the backlog of services to people, and as population ages and as population grows, we have the capacity that is needed to provide Ontarians with the care that they need. Next slide, please, Tara. So the strategy is divided into three pillars, which are listed here. And the really basic way to understand these three pillars, and we'll walk through each of them in detail, is the pillar one is the idea of getting the right care in the right place. And what this is the bundle of things that government is doing to try to restructure how the healthcare system is organized. The second, pillar two, faster access to care, is really about trying to make that system not only better organized, but also bigger. So just more hospitals, more long-term care beds, just having more of a system in addition to being better organized. And the third of the pillars, hiring more healthcare workers, is you have a better organized system that is bigger. You need people, of course, to work within that system to staff it. And we have an HHR crisis in this province. And so how do you go about ensuring that all those new buildings, the long-term care beds, are appropriately staffed? Minister Jones has been very clear in saying the idea that the status quo is not working, bold reform is needed. And I think the kind of, no one really would disagree with that. The question and debate is about whether and to what extent these particular changes to the status quo are either too much of a break from history, not enough of a break from history, and whether this, your health strategy is going to sort of fully meet the needs going forward. So going through the pillars, the first pillar of the strategy is the idea of the right care in the right place. This is for those of you that sort of enjoy looking at kind of the history of healthcare policy and have been following for the last while. Sort of over the previous decade, this is the kind of thing that's been very much the focus of healthcare reform in Ontario. It is the idea of, we have a system that has a lot of silos, it is highly fragmented, it is very centered around hospitals and where providers happen to be, and not centered enough around where the patient is. And we need to reorganize the healthcare system so that patients have more options that better meet their needs, are more convenient, closer to home, et cetera. So this kind of reform has really been a major driver of healthcare reform in Ontario for quite some time. And when the Conservative government, the PC government, came into power in 2018, they immediately focused on a lot of activities in this space. Essentially, how do you restructure the system? How do you do more with less and improve services by just organizing things better? The flagship component of this was and remains Ontario Health Teams as the sort of locus of organization for healthcare services. So Ontario still has a vision for Ontario Health Teams to be the organizing principle of local healthcare. But beyond that, they're doing an awful lot around changing the kinds of services that one can access in your local community without having to go to a more traditional healthcare setting. So that includes things like expanding care and what pharmacists can do. It includes enhancing the range of mental health services. It includes providing digital options like the new Health 811 service that if you, like me, watch TV online, you've probably seen ads for this over and over again. They're pushing very hard the idea that there are new options available to Ontarians to access care in more convenient sort of omni-channel ways without having to rely on the sort of more traditional structuring of the healthcare system. So this is a basket of reforms that really are focused on the idea of providing more integrated care options, more options period, closer to home, more convenient, just really how do you reorganize the system? And as I said, this has been really the focus of healthcare reform for quite some time. This has been a big focus area of this government in particular. But if you go to the next slide, Taryn, the most substantial change recently in 2023 was the expansion of the prescription by pharmacists for 13 common minor ailments. This is an expansion of scope, but it's very much predicated on the idea that family doctors are very busy, have a lot to do. These are services that can be provided by pharmacists, and notably, people tend to have pretty convenient, ready access to a pharmacist close to home, whereas accessing a family doctor is not typically as convenient. So really, this is about trying to improve access to care for relatively high volume services in a way that really meets patients where they are and organizes services for these kinds of things in a more patient-centric fashion. So next slide, please, Sarah. So for this pillar, really this is a return to what the government's big picture vision was for the healthcare system prior to the pandemic, with obviously many specifics changed, but it's a return to that big picture idea of we can do much more and much better simply by reorganizing the services that we have, enabling providers to work better to their scope of practice, enabling services to be provided in different settings. So it's, I think, very importantly listed as the first pillar of the strategy, because as much as there is a lot of focus and discussion about how we better invest in the system and increase HHR, there is this long-standing challenge in Ontario's healthcare system that the system is fragmented and siloed, and regardless of current challenges, that remains a pressing priority. So moving forward, there's still lots to do. I think the OHT strategy, there was a major announcement a few months ago around OHT governance, and the idea of sort of the next phase of OHTs. That's going to likely occupy a lot of government time and system time in the coming years. We expect there to be significant movement on home care modernization. This is an area that's been discussed as a sort of sector that needs reform without there being a sort of long-term vision of what the future home care model looks like. And we think that that will be coming as an area of priority for consultation and strategy in the next little while. And also that sort of continued expansion of the services that are provided in pharmacies and labs and how they're provided in those settings. We expect that to continue as a trend as the settings that patients tend to have the easiest time accessing and that have the ability to do a lot for patients. Dan, did you want to elaborate on any of that or any thoughts to add to that?
Yeah, I just wanted to kind of add to the conversation a few thoughts, and that in what Ben went through, there's a real dichotomy between what I describe as the easy wins for the government in this area of activity. So when you look at health policy and the ability to drive change from the government perspective, changing the scope of practice of a pharmacist is relatively easy. It's done through legislation with the stroke of a pen. It's relatively easy to implement. Getting an 811 number stood up, relatively straightforward, not very complex. Making some announcements that you're going to open some additional family health teams or you're going to add hospital bed capacity at some point. Relatively easy, relatively straightforward. Again, the other components, though, that Ben has spoken to as part of this strategy that are really essential to meeting those long-term secular challenges in the healthcare system related to profound aging of the population and population growth, those changes that really are required to reorient the system away from the kind of historical reliance on acute care services and medical services, on treating people only when they're sick and then figuring out what to do with them, and shifting to a strategy that I think successive governments have identified as crucial for the past 20 years, which is reorienting the system to a strong foundation in primary care, where patients have medical homes in the community that deal with their overall health and wellness, having a strong integrated community-based home and community care system, having a strong mental health and addiction system, and having a focus on population health planning at the local and regional level. These are all things that the government has announced. These are all things that are incredibly complex and both complex and complicated to implement, and they are currently stuck. We will see potentially more announcements in coming months about how the government is going to be moving forward with home care, how they're going to be moving forward with primary care. But I think it's important to recognize that for 20 years, we've been talking about these trends in healthcare, and implementing the change is incredibly difficult. And we haven't yet seen, and you can use COVID as I think a very valid rationale for the past few years. We haven't yet seen a commitment from this government to really roll up its sleeves with the complexity of health policy and continue to drive forward on this kind of change. So really the proof will be in the pudding as to whether the government is fully committed to OHTs, whether it's fully committed to home care modernization and reform, and fully committed to building out primary care as the strong foundation of the system. Okay, with that, we'll move on to Pillar 2.
Yeah. So Pillar 2 is the faster access to care pillar. I like to think of it though as really the shovels in the ground pillar. This government, when it was first elected almost 5 years ago now, made a commitment to a certain number of long-term care beds within a sort of 10-year period, and that has continued. There's lots of growth and development in long-term care, but they have also recently made a massive number of commitments around, I believe it was a $40 billion over 10-year investment in hospital capacity, new hospital buildings, new hospital locations, large commitments to increase the number and volume of diagnostic services, increases in just the pure volume and access of mental health services and palliative care services. There is basically a concerted effort to just grow the size of the system by pumping money into the system and investing in capital. So there's a lot of sort of diversity in the details of this, but the sort of core idea is, you can make some progress in improving access by reorganizing things, but to Dan's point, a lot of that reorganization is really hard, but you can also improve access to things by simply creating more things to access in communities that are fast growing, that maybe don't have services locally. So this is really about growth. In addition to that growth, if you can go to the next slide, Taryn, there's also a degree of reform in creating new kinds of locations for practice. So as we would have seen a couple weeks ago now, there was the introduction of Bill 60, the Your Health Act, which is a major restructuring of the independent health facilities model and renaming and replacing IHFs with what are now called Integrated Community Health Service Centers, or ICHSCs. And these are going to be OHIP-funded settings that will enable the delivery of surgical and diagnostic services with many, many details to be determined. Very critically, I think the legislation is structured in a very enabling fashion. The legislation basically gives the government sets a set of requirements for government to define a sort of structure for quality and safety and oversight. It creates requirements around staffing plans and the creation of sort of contingency planning around staffing. But what it doesn't do is specify any of the details of what those must entail. It's all sort of structured so that the government can, in future, define this sort of as they see fit based on need. And it creates a degree of flexibility that did not previously exist in the IHF model, where IHF legislation was very restrictive in terms of what government could do. This enables government to, if they so choose, conduct many, many, many calls for applications for many, many kinds of service providers, or not, if they so choose. So really, it lays the groundwork for a lot of reform. It sets a sort of tone around the kinds of guardrails they intend to create, but creates tremendous flexibility in terms of actually defining the specifics of those guardrails, what kinds of services they open up, where, etc. If you go to the next slide, Taryn. So that legislation, so besides what we talked about, sort of the shovels in the ground growing things, I think that legislation and the next steps on that legislation will occupy a lot of the attention of decision makers in the coming months. It's obviously already occupying a great deal of people's attention in terms of sort of the dialogue and debate in the legislature and elsewhere. The first step, obviously, is to actually pass the legislation, which we expect to happen in the next few weeks to month. After that, we expect government to firm up what that oversight and inspection regime actually looks like. So what are the sort of rules of the game around these new centers? What we do not know is whether government will, after legislation passes, go the next step of defining regulations that would basically create a common set of rules around things like staffing plans and what a staffing plan needs to entail. They could alternatively choose, instead of defining this in regulation, to just in any given application define the rules on a case-by-case basis for what those staffing plans and other things need to be. So regulations may or may not happen. They may or may not be highly detailed, and the sort of details to be defined may actually happen in the application phase instead of the regulation phase. Regardless of whether regulations happen or not, we expect fairly soon there to be a set of applications, calls for application that will occur to actually create new centers. There's an initial focus on cataracts, which is already underway, as well as probably an expansion to hip and knee surgery shortly after legislation is passed. In the medium term, we think diagnostics will be a key area of focus, but really the legislation leaves the door open for any number of procedures and types of centers to be established. So as need evolves in the coming years, as the public discourse changes, there is a lot of potential for this legislation to lead to a lot of new organizations to be set up, or for organizations to be expanded to provide new kinds of care in new kinds of settings. Dan, anything you want to elaborate on that one?
Yeah, I think, again, similar to my comments on Pillar 1, a lot of the activity under here is really divided into what you could consider the easy work of government versus the hard work of government. The easy work in building out capacity is to just do more of the same. We're going to give Trillium more money to provide more hospital beds. We're going to provide long-term care license holders more licenses to build beds out. We're going to build more palliative centers built on a model we already have. Even this ambulatory work can really be divided into slightly more of the same versus that kind of change in how you deliver services that the legislation points to in the future. So it's relatively easy to roll out cataracts or individual diagnostic services, or even hip and knees, which a few years ago would have been seen as a bit of a leap, to existing clinics, existing practices that do these. The trickier thing that this legislation kind of speaks to is the longer term ambition to really think about system capacity in a regional way, where you can have ambulatory centers that offer a range of surgical and diagnostic services, working closely and collaboratively with local hospitals. Saw a lot during COVID that ICU patients were transitioned, that you shared capacity across the system. Really, over the longer term, there's a recognition that you need to take a similar approach to load balancing for surgery and diagnostics and a whole host of things. But how do you get the hospitals to work together with ambulatory centers? How do you drive a common approach to health human resources and physician credentialing or privileging in the region? How do you ensure central intake? How do you deal with triage? How do you deal with all of the financial incentives that are currently really inhibit collaboration between organizations within a given region to really ensure that patients get the fastest and best access in that region? So there's multiple years of work there. Kevin Smith was on the cover of Hospital News. I think if you walk down University Avenue, you can see it and pick it up. It says, this is a great thing that the government's going to be doing this, but the devil's in the details. The Ontario Hospital Association said essentially the same thing. The Ontario Medical Association has been supportive of this approach, but they keep saying the same thing, which is to capture this kind of transformative benefit of really a system that is not entirely dependent on inpatient organizations as standalones to do everything. We really need to figure out how all the pieces fit together, and that's quite a lot of detailed policy work over the next couple of years. And we need to see the government being committed to doing that work and working through the messiness, the murkiness, the the difficulty of the sausage making process in healthcare.
Yeah, and I think this sort of timeline here articulates the idea that the sort of the devil's in the detail conversation may happen in the next 2 to 3 months, but really it's probably going to be sort of a multi-year dialogue as any given application occurs or any given application is planned for. There will be debate about what the specific terms of any application are, what the kind of planning requirements are. So we expect this to be a pretty pressing area of policy in the next few years. Moving on to pillar 3, I'm going to pass it over to my colleague Ian to walk through this one.
Thanks, Ben. So of course, a big part of this is health human resources, and basically what we mean by that is you'll hear the term HHR or HHR planning, and the staffing shortage is really a problem that's at root for a lot of the other issues across the health system. So of course, this is really a baseline challenge that, and this isn't just Ontario, but all governments have not really kept up to pace with over the last number of years. And of course, what we saw with COVID was really all of those problems kind of bubbling over and coming to the forefront. And maybe I'll just start by noting that going back to my colleague's point about the FAO report that came out today, really kind of underscores this challenge when it noted that by 2027, 28, the report says that Ontario needs just over 86,000 additional nurses and PSWs. And that represents a 26% increase in nurses and a 45% increase in PSWs. And that's just to maintain access in the system. And of course, that's not including what I see someone pointed out in the chat, which is, of course, the shortage of access to family physicians that many of us have experienced and we see talked about quite a bit in the media. So HHR, it's always been a difficult strategy. The solutions are always multi-pronged. There is no silver bullet to addressing the HHR challenges that this province is seeing. And that's really, I think, reflective of why you see kind of this, what, on the surface might appear to be sort of these one-off kind of programmatic announcements or solutions designed to address the issues. But of course, wrapped together are all designed to address the shortage in a number of different ways. I think, before we get into the details a little bit more, I think the problem for this government is it's less about kind of almost the individual strategies. Certainly those are extremely important, but it's the kind of long-term maintenance and system planning. A lot of that goes back to, regular monitoring of data, better access to data, frankly, so that investments are upstream and are smarter, because a lot of these solutions are intended to alleviate the problem over the coming years. And so a big part of that is going to be better kind of data and management. And that's not necessarily something that we see kind of coming through here. And that's not something that the government has been very effective at historically in this area, particularly. Next slide, please. So of course, a big part of this is a focus around education and training. So going back to, it's a multi-pronged approach. So, there's a focus on the Learn and Stay grant and ensuring better access to education spots, particularly for nursing, paramedic, and medical lab tech programs, as well as increased educational spots for physician assistants and other healthcare professionals. Again, this is, this is sort of in some ways, the traditional response to shortages in health human resources. So it's not really a novel approach. I think where the government is still missing in the long term is better alignment, frankly, between our pedagogy and our educational system, and ultimately what the needs are in terms of outputs on the other end. And that's where I think, in the media, you see a lot of stories about, there's shortage among nurses, but then there are many people who can't get into nursing programs, right? And can't kind of get the credential in order to be able to become licensed. And so those gaps are likely going to continue to exist. But certainly this is the government trying to kind of kickstart the system and help, in the more shorter term, increase some of these professionals in certain key areas. The next slide. And there's also a lot of regulatory changes that are going into this. So a big one, of course, was the as of right announcement in Bill 60. This one is interesting because it was actually announced a few weeks ago, and the initial announcement sort of appeared to be health professional wide. And what essentially as of right means is that if you're a licensed health professional in another province, that under these new rules, you could come and automatically start working in certain sectors, particularly hospitals in Ontario. The announcement back a few weeks ago appeared to be a little bit broader in scope. It seems to have been a bit scaled back with Bill 60 being introduced more recently, and the focus seems to just be on physicians and nurses, but it's still unclear kind of how wide or the government wants to go with that kind of policy approach. The challenge with that, of course, is you do risk blowback from other provinces and territories because, of course, the HHR shortage is not unique to Ontario. So it could be an approach that risks draining health professionals from other provinces. Of course, scope of practice is a big part, as Ben mentioned earlier. The common ailments prescribing for pharmacists is one example of this. There's also a number of other areas, and we see some intention from the government to try to move and expand scope of practice for other health professionals. This has always been an area that's been, the government's been pretty risk adverse around, largely due to concerns about creating redundancies among professions or just cost concerns. But again, given where we are at currently with the state of the HHR challenges, we do see the government being a little bit more nimble in this area. So it'll be interesting to see in the long term how that trend might continue. And of course, this is something that was not super new, but there was the creation of the the Care Providers Oversight Agency for PSWs, and that is still kind of in a transition state. But that is certainly continuing to move along, and that is really one example of where I think the government recognizes, at the same time, if there's going to be a desire to, if they're given that there's a need for increased access for health professionals all across the spectrum, there are a number of professionals who are currently unregulated. Of course, a lot of this was spurred due to regulatory concerns with respect to personal support workers. But really, I think what this agency might serve as is a bit of a model for how to get health professionals regulated in a more kind of quick and nimble way, as opposed to just adding a 27th college, which the government has been opposed to taking that kind of route. And of course, emergency classes of registration are going to be implemented across all regulated health professionals. Currently, all of the 26 colleges have been busy working on regulatory amendments to add an emergency class, and a lot of that is actually undergoing consultation right now, and those regulations will likely be submitted to the government by the end of March or early April, and we're likely to see that approved pretty quickly by the government in order to kind of make sure that the system is a little bit better prepared to take on additional professionals. So I think what you're seeing here is, you're not necessarily seeing a lot of new ideas, and some are new, of course, like as of right, we haven't seen that type of change previously, and we haven't seen really enough yet on scope of practice, I don't think, to really make a lot of a judgment on it. So you're seeing a lot of some of the same and some new, but there clearly is an understanding that their system from a regulatory perspective needs to be a little bit more nimble in order to be able to face the challenges with the staffing shortages that are causing so many problems across the system. And the next slide, please. So, this is certainly one of the most significant areas to keep an eye on in the months and of course years ahead. But going back to my earlier point, I think what we really still don't see, we see a lot of kind of individual programmatic changes or regulatory changes that ideally collectively, again, it's all part of a multi-pronged strategy in order to address staffing shortages across the system. But the hard part is going to be that kind of long-term maintenance and making sure that you're both recruiting new health professionals, but also retaining capacity in the system. And, you know, a lot of health professions are having problems with attrition. We've seen really significantly high rates of burnout throughout the profession. That's led to a lot of early retirements, not just in nursing. So the government's facing this challenge really from two perspectives, both attrition and people leaving the profession, and then also needing to ensure we kind of have a faster recruitment into these roles to make sure that the capacity needs are maintained in the long term. And again, going back to that FAO report from this morning, that's a very daunting task that this government is facing. And so, you know, this is certainly part of addressing that challenge, but there's a lot more that will need to be done in the long term. Dan, I don't know if you wanted to add a few comments here.
Yeah, there's a few things I think that the government's going to need to think about, or the system's going to need to think about over the long term. I mean, and it is good to give the government credit that they are thinking about this issue in a long-term way. They're looking at a 10-year capacity plan to match their investments to the need for human resources, so they can, as an example, address that need for 87,000 new frontline providers over the next 6 years that the Fiscal Accountability Office pointed out. A lot of the things that you do in health human resources, whether it's open new medical schools or have fill new medical school spots, can take 3, 4, 5, 6, 7+ years to really benefit the system. So it can be quite frustrating when you're dealing with a clear and present challenge at the moment. So there's a portfolio of activity, some of it which will make a difference today, some of it will only make a difference years down the line. The other things to keep in mind is that health human resources growth, you need to think about it as a labor market. Sorry, I've just got something in my throat. Let me clear this. Traditional labor markets would address labor shortages through two main areas of activity. The first would be that you would increase wages. So if you don't have enough people, you increase wages and you get more of them. The government artificially, through Bill 124, stopped the ability of employers to increase the wages to address labor shortages. That's Bill 124 is now coming to an end. Its legal status is in question. But inevitably, if you're going to attract tens of thousands of additional people to work in a sector that you've been struggling with, you have to see wages increase. And that's something that I think this government hasn't really come to terms with yet. They want, and I can understand this, they want additional investment in the healthcare system to result in additional capacity and improvements in access. But there's going to need to be a lot of investment that is just about retaining staff and attracting new staff in and seeing the wage level in the system increase. That is inevitable. The second piece of labor market economics that really hasn't been thought of too much is usually employers with labor scarcity would think about how do they improve the productivity of the workforce. What are new delivery models look like that reduce reliance on expensive staff? What does automation look like? How do we deploy things like machine learning and other tools to reduce very expensive human resources? Healthcare is way behind other sectors of the economy in that. There's a lot of reasons for that. Part of it is the regulatory complexity that Ian talked about. There are some small steps in that direction through looking at nurse practitioners and physician assistants and what personal support workers can do. But there needs to be, I think, a bit more rigorous thinking about how you drive health system productivity over the long term so that you don't just take a straight line projection and say, to get the same kind of poor access that we have today, we need 87,000 people doing the same thing 6 years from now as they're doing today. We need to rethink about what these people are going to be doing in the roles and how everyone in the system works more effectively. So I think that's some thinking that has to take place behind the scenes, behind these kind of small engineering fixes that Ian has spoken about as part of the current plan. Now I'm going to hand over to Steph to wrap things up and transition us to the questions.
Thanks, Dan. Just a reminder, and we have a lot of questions coming in. Please use the Q&A function at the bottom. There's a lot of folks on the line today, so I'm sure there are a lot of questions. But next slide, please, Taryn. Just to wrap things up, as I mentioned, Ontario will be tabling the budget on March 23rd. And we've heard tidbits already from Minister Bethlen Volvey on sort of the three core pillars to what he's looking at in the budget to building the economy in Ontario. So focusing on labor, interesting after the sort of section we just looked at, infrastructure and attracting investments to Ontario. In the health space specifically, the minister has spoken about advancing technology and life sciences as a main priority and pillar to build Ontario's economy, which is also interesting as we've yet to see the rollout of the anticipated Life Sciences Council and any further work on that. I wouldn't be surprised as well if the budget is considered a more of a typical PC budget. The minister has said now is the time for significant restraint after high levels of spending throughout the pandemic, and really to ensure sort of a strong future for Ontario given the rocky and uncertain economic times. And as was the case in the 2022 pre-election budget and the general election, health remains a top priority for the PC government, but not the only priority. And I think, they'll be really focused on spending the time rolling out everything that we discussed today in the Your Health Plan, the regulations, and most likely, the call for applications to expedite these new ICHSCs. We'll get that acronym eventually, right, Ben? So with that, we're going to open it up to Q&A, and we have a lot of questions already coming in. So I think the first one that we'll go to is, Ben, maybe this one, you'll take this one, is how will communication between family physicians and pharmacists evolve?
Yeah, it's a great question. And I think, for a very long time, the question of how pharmacists and family practice can communicate has been a challenge. Like, it's always administratively a bit tricky. And I'm sure if you asked a pharmacist about some of the sort of day-to-day challenges of their practice, this would be on the list. And I think the expansion of the 13 common minor ailments might exacerbate that challenge and creating sort of more of a need for pharmacists and family practice to communicate. I think government in the Your Health strategy as well made sort of an announcement around Axe the Facts as an idea in the next 5 years. And I strongly suspect that part of Axing the Facts will include figuring out how to enable e-prescribing between family practice and pharmacy. There are a number of e-prescribing solutions that do a really good job of enabling communications between settings. I think there are good solutions in place, but obviously it takes time to roll these things out. So I suspect in the next few months to a year, there will be more clarity on what that looks like. And I think that sort of the idea of pharmacists being kind of extension of family practice or being more integrated with it will become more and more a reality as a very convenient, accessible, close to home care option that will in future have hopefully relatively easy mechanisms to enable information sharing of primary care.
Great. Ian, I think this one's for you. Do you foresee the as of right rule being extended to US trained physicians following the Nova Scotia government announcement earlier this week?
Yeah, I think it's possible. And certainly with respect to physicians or nurses, that could be a direction the government can move. I think the hesitancy is probably less about, of course, so far, the Ontario government has not announced an intention to make this applicable with respect to US jurisdictions, but I think the hesitancy has really been more about expanding it beyond other health professions. And certainly for Ontario, there is a challenge when you have professions regulated differently across different provinces or different jurisdictions. And again, that could be in US states where scope of practice is different. That's likely less of an issue, of course, among physicians and arguably maybe even nurses to some extent, but that's really where I think a big part of the problem comes. And I think what we saw in the Ontario in Bill 60 was, a significant kind of paring down from what was originally announced, which sounded a lot kind of broader in scope. So it's quite possible, particularly if they see another jurisdiction moving, like Nova Scotia moving in that direction.
Great. Dan, I'm going to pass these to you, and I'm going to merge sort of two questions here. One is more of a comment around sort of the Your Health strategy really has no mention of priority populations and the way we will be impacted, or the needs in sort of a targeted way. And the other question is really looking at sort of reducing health inequities as part of the health plan and being a bit of a gap. So if you could address those two questions.
Yeah, Ben might want to comment on this as well, because I know he had attended a session recently hosted by Ontario Health. I think when on Ontario Health as the key delivery agent, or the bridge to the delivery system for the government, is looking at how to implement health reform, it is taking a very strong approach, looking at priority populations, health equity, and the social determinants of health. They've spent a lot of time developing a kind of health equity framework that they're trying to build into the accountability agreements with all health service providers. There's work underway within Ontario Health about developing a social determinants of health framework that should underpin all of their work. So I see that lens being very strongly applied at the Ontario Health level. And I think there's the expectation that it's going to be embedded through the work that Ontario Health teams are doing. And I know from working with a lot of Ontario Health teams that the priority populations and addressing the gaps in both care and the gaps in outcomes for populations has been a key focus of their work. But I think you're right in terms of how this government-facing communication was packaged. It's less front and center in this, which is, I would, and I think there were some comments to this effect earlier, it's positioned as more of a broad-based communications vehicle that combines a lot of different activities that were already underway in the health system. Ben, I don't know if you have anything else to add on that.
Yeah, so as Dan alluded to, I saw Matt Anderson, the CEO of Ontario Health, give a talk yesterday, and he was very, very clear in sort of the priority of what he said and the emphasis that sort of an anti-racism lens and a sort of Indigenous equity lens. These are all things that I believe he and they take very seriously and have as a priority. So I think the sort of equity lens is at a certain level being applied. One can, of course, argue whether it's being applied well enough or et cetera. So I don't want to sort of get into that. But I think the attention is there to sort of that as a priority area. But I think to Dan's point about sort of Your Health as a strategy being a broad-based communications lens, really the focus was the system just needs to be bigger, better staffed, et cetera. And so I don't think it really emphasized that lens.
So Ben, maybe these are questions for you. What are you hearing or seeing in terms of the interoperability front for digital health, key challenges, opportunities? And then another question is really around sort of digital strategy for the government. So if you can share anything on both of those.
Yeah, so I could talk about this for another hour, but I won't. But so maybe I will in a month or two in another webinar. I think on interoperability, I would say the government's approach has been a brainstorm every idea you could have to make it better and try all those things. Like it's a real all of the above strategy. So they are, for instance, paying one vendor to integrate one setting with another in various cases. They're defining standards and have legislative authority to mandate standards around interoperability. They are paying OHTs to migrate to a single platform so that it's easier to share information. They're paying vendors to roll out specific integrations for primary care practices to access the digital health drug repository, for instance. So really, interoperability has for a very long time been seen as sort of a key gap in the system, and they're doing a bit of an all of the above approach, which you could argue is either necessary or messy, but that's sort of roughly the approach they're taking. As far as where this is going, like really for the last quite some time, primary care has been the key focus of questions of interoperability. It's really driven by like, why can't my record move from primary care to wherever else? So I think that will continue to be the case, that the government will be highly focused on primary care. That's also because primary care vendors are largely Canadian vendors, that the government has an easier time sort of working sort of mandating than they would the large American hospital information system vendors who might not see Ontario as sort of a priority market. So primary care will be the focus. Sort of the new emerging focus that I think is really interesting, though, is the idea of primary care home care integration as sort of a focal area for OHTs and just in general. There's this idea that home care modernization should include home care becoming almost an extension of and better integrated with primary care, and digital as enabler of that has potential to be very powerful. So I expect sort of the new thing over the next year to be primary care, home care integration as a potential area for investment or focus. On the challenge question, I think the issue that gets a little bit less attention, but that I think will become more and more prevalent, is the sort of tension between interoperability and burnout as sort of pressing issues. So when you think about sort of administrative tasks for physicians, there is sort of nothing more irritating than having to like retype your notes to be structured just so that the information can be shared. Like you wrote DM2 instead of diabetes mellitus 2. You can't do that. Like just that sort of very nitpicky data standards work could be a big contributor to burnout. Or also, I heard a story yesterday about a hospital that automated their reporting from hospital to primary care, but in doing so, primary care became inundated with all these like reports that they had to review. And so the hospital, in reducing their burnout challenge, created a bigger one in primary care. So I think there's a lot of sort of challenge there around how you structure data sharing and collaboration in a way that doesn't drive more burnout, that I think will, as the reality of all this sets in, become more and more pressing. To the sort of macro question of where is the e-health and digital health strategy, I strongly suspect government will be announcing either in a large way or a quieter way, or releasing sort of a new digital health strategy in the next few months. I saw a talk yesterday from Michael Hilmer, who basically alluded to this likely happening. So there'll probably be something that's coming. What is less clear is back in 2019, they announced sort of the digital first for health strategy, but they didn't provide a lot of details, whether the strategy is comprehensive and detailed, or whether it's relatively simple and straightforward and requires people to kind of cobble together all sorts of things to sort of figure out how it all fits together. That is TBD, but I expect there to be sort of a new branding and a new area of focus sometime maybe this spring.
Great. We have a lot of questions and only a short time left. So really quick answers. Ian, anything specific you're hearing on nurse practitioners or new NP models of care?
No, I mean, I think really for this part in the strategy, we're seeing more of the same. There's a continued focus on nurse practitioner-led clinics. That's not something that's a new concept and that the government's been funding for a little while now. I think in the long term, the conversation that's going to continue to be pretty pressing is at what point are there regulatory changes made to allow nurse practitioners to roster patients themselves and take on a much more even independent role in kind of family primary care, particularly given the challenges around access to family physicians, because it's still sort of in the kind of more like the walk-in kind of clinic model. So that will be interesting to see in the long term.
Great. Ben, Dan, over to you. I'm going to merge sort of two of the questions. What type of organizations do you think will be applying for the new independent health facilities? And are there safeguards in place in the legislation to ensure sort of productive and accessible balance between public and private funding models? Ben, do you want to start with that one?
Yeah, so I think to the point made before, but the devil's in the details. The legislation enables them to structure this in any number of ways. They could structure an application that is only open to not-for-profits. They could structure it so that it is open or not open to hospitals. I don't see anything in legislation that precludes that. So really, this is the big question we're monitoring is how do you structure this? Who is it open to, under what terms? I think the important thing, though, is, so the question I think referenced public versus private funding. I think the legislation does nothing